So hypertension is a ginormous topic, and I didn't really know if I wanted to put it in the nephrology section or in the cardiology section, since it has to do with both. But since most of the treatments for hypertension are focused on the kidney, and since there are a lot of causes of hypertension that involve the kidney, I decided to put it in the nephrology section. So, hypertension is the most common disease in the U.S., so you can imagine you're going to get a lot of questions related or revolving around hypertension on the USMLE. We don't treat hypertension right away unless there are hypertensive symptoms present, and that's considered a hypertensive crisis, which we'll talk about what exactly that is later on. When we do treat hypertension in a relatively asymptomatic person is if their blood pressure is greater than 140/90 in any patient, and this has happened on 3 occasions. We also treat the patient if their blood pressure is greater than 130/80 in more than 3 occasions if they have diabetes mellitus, vascular, or renal disease. So the cutoff is going to be lower if they have these other risk factors like diabetes, vascular disease, or renal disease that could raise their risk towards some of the other problems that can come from hypertension. Many of the causes are idiopathic, and this is what we call essential hypertension. And then there are a lot of complications that come out of the hypertension. When there is a known underlying cause for the hypertension, then we consider that to be secondary hypertension. In an otherwise healthy patient, the USMLE will test you on this. Don't jump straight to a medical treatment. The USMLE often will tell you that a patient comes in and they have a blood pressure of 150/95. They're otherwise healthy and they have no other symptoms, no significant history. What's your next step, or what's your treatment plan for this patient? And the answer will not be to jump to pharmacotherapy. It will just be lifestyle modifications. So the only time we use pharmacotherapy is when we have a patient that's had more than 3 episodes of hypertension, or if they have an episode of hypertension and there are hypertensive symptoms that are present. So hypertension is the #1 cause of stroke, peripheral artery disease, coronary artery disease, and end-stage renal disease. And a lot of people who have hypertension also have other concurrent problems. So just having isolated hypertension alone does not necessarily mean you're going to have these problems, but we do look at it as a marker of other problems possibly existing. So anytime we have a patient who has diagnosed hypertension, we want to do a good workup. Okay, so here are the 3 things we're going to talk about. We're going to talk about asymptomatic essential hypertension, which is broken down into mild or moderate or severe. And then we're going to talk about the symptomatic essential hypertension. So remember, essential hypertension just means that we don't know the cause. You could just as easily insert the word idiopathic for essential. And the symptomatic essential hypertension is what's known as a hypertensive emergency. And then we'll talk about the various causes and treatments for secondary hypertension, which is when hypertension is a manifestation of an underlying problem. So the first thing we have to do for hypertension is to establish the diagnosis. And so if it ever says that the patient is on their first visit, or this is the first time that they've had a hypertensive reading, then what you're going to want to know mostly is that you don't treat a patient unless they have symptoms of hypertension, which would be mostly neurologic symptoms, cardiac symptoms. If they don't have any symptoms related to their hypertension, you don't treat the hypertension if this is just their first go at it. So the patient will usually be in for the routine labs, maybe they're in for their diabetes check or so forth, they'll have no complaints, but then you get a blood pressure and it's elevated. So it's greater than 130/80 if they have diabetes mellitus or renal disease or any of those other disorders that I listed there, or it's greater than 140/90 in an otherwise healthy patient. In these cases, if it's just the first time, you don't start pharmacotherapy. You're going to recheck it a month later. And you have to establish 3 hypertensive readings in order to start pharmacotherapy. If the blood pressure is greater than 160 over 110, this is the cutoff for severe essential hypertension. But again, if the patient has no symptoms, we're not going to treat it right away. We're going to have them come back in maybe 2, 3, 4 weeks later. The treatment, like I said, is to advise lifestyle modifications, diet and exercise, and absolutely get a recheck within a month, because we need to have 3 abnormal readings to diagnose essential hypertension. Patients who have a blood pressure that's significantly over 140 over 90, they're probably going to be diagnosed with hypertension, but we don't start therapy until they have 3 abnormal readings to make the diagnosis. So essential hypertension will be your diagnosis when the patient has had 3 readings where the blood pressure has been over 130 over 80, and they have a history of diabetes mellitus, renal disease, congestive heart failure, stroke, TIA, myocardial infarction, peripheral artery disease. Or their blood pressure is greater than 140 over 80 and the patient has no other significant history. So remember, we keep the cutoff lower if they have these other risk factors towards the complications that can come out of hypertension. We also diagnose essential hypertension if the patient has no symptoms it's another criteria for essential hypertension that the patient has no symptoms of an underlying cause. So if the patient fits the criteria for having 3 or more readings greater than 140 over 80 and no other significant hypertensive symptoms, but they have striae and edema and a low potassium, that's going to probably be secondary hypertension, because there's probably another disease process there that's causing hypertension as a symptom. So we have to exclude secondary hypertension, and generally we just do that by making sure there's no other symptoms of things that would cause hypertension as a secondary cause. When we talk about the secondary hypertension, the various causes of secondary hypertension, you can see what the various things are that you'll want to rule out. So we have to rule out secondary hypertension in any patient that we diagnose essential hypertension. And essential hypertension is about 20 times more common than secondary hypertension. So usually essential hypertension will be your diagnosis, but you do have to rule out any possible underlying cause. So the labs to get after you've made the diagnosis of essential hypertension, you want to get a urinalysis, and the reason we get a urinalysis and a complete metabolic profile for that matter is because we want to see if there's any damage to the kidney. So we want to see if there's microalbuminuria, we want to see if there's glucosuria, because that will tell us if there's any damage to the kidney. We want to have a BUN and creatinine level, because that'll tell us if there's any damage to the kidney. We want to get a glucose level because this patient may have developed type 2 diabetes, and if they have, we want to know that. We want to get a potassium level as well, because that will show if there's any renal dysfunction. We want to get an EKG because if this patient has had hypertension for a long time, then we want to check to see if there's any structural abnormalities of the heart. Particularly what we'd be looking for is left ventricular hypertrophy, which would come from a hypertrophic cardiomyopathy. And then we want to have a serum lipid profile because we want to see if we need to treat this patient with statins if they have an elevated LDL cholesterol. And that's simply because having an elevated LDL in consort with hypertension is going to greatly multiply your risk of complications. So, treating essential hypertension. So now we have this patient that has had 3 or more abnormal readings. And so what do we do for treatment? The initial drug of choice in a non-comorbid patient, so we're talking about a patient that doesn't have any other necessarily related disease processes. So we're not talking about the patient who is diabetic or a patient who has high cholesterol, etc. the drug of choice is going to be a thiazide diuretic. Thiazide diuretic is the best initial treatment for essential hypertension. So this would be something like hydrochlorothiazide. And then we'll monitor these patients over 3 to 6 months to see what happens to their hypertension. Diuretics have the best reduction in mortality for essential hypertension. Now, if the patient has a severe essential hypertension, so if it's greater than 160 over 110, and the patient has hypertension in that case, then we would want to start them on 2 drugs. So greater than 160 over 110 on 3 visits, then we want to start them on 2 drugs. And generally that will be both the thiazide diuretic that we would originally give them and an ACE inhibitor or angiotensin receptor blocker. So always give them a thiazide diuretic, but if it's a severe essential hypertension, so 3 readings of greater than 160 over 110, then you'll add on either an ACE inhibitor or an angiotensin receptor blocker. We use the ACE inhibitor most of the time, but if the patient has an adverse reaction, like usually a cough, or the patient is African American, then we will lean towards an angiotensin receptor blocker. Now, the USMLE is going to want you to know how to individualize your therapy. So if this is a patient that you've diagnosed hypertension in, and the patient is pregnant, then or if it's a patient who has hypertension and she becomes pregnant, you can't use diuretics in these patients. You can't even use ACE inhibitors in these patients. You need to use alpha-methyldopa or labetalol or a calcium channel blocker, which would be amlodipine, verapamil, or diltiazem. So if the patient is pregnant and you diagnose the hypertension, which if it's a new hypertension in a pregnant patient, then you should think about something else that we'll talk about at the very end. Or if the patient already has essential hypertension and they become pregnant, then we're going to need to change their therapy. We need to get them off their diuretics, get them off their ACE inhibitors, and start them on methyldopa, labetalol, or calcium channel blockers. If the patient has essential hypertension, which we've newly diagnosed, and they also happen to have diabetes mellitus, or on their urinalysis they have microalbuminuria, then in addition to the thiazide diuretic, the hydrochlorothiazide, we're going to give them an ACE inhibitor too, because the ACE inhibitor is going to preserve renal function. Like I mentioned earlier, black patients tend to do poorer on ACE inhibitors, so anytime when you would give the patient an ACE inhibitor, if they're black, then you should lean towards the angiotensin receptor blocker. If the patient has congestive heart failure, particularly if they have left ventricular hypertrophy, then you're going to want to consider adding a beta blocker in addition to whatever else you may be giving them. So propranolol or metoprolol. So this is all in addition, except for the pregnant patient, this is all in addition to your first treatment of choice, which is a thiazide diuretic. This is just cases where you would individualize therapy based on comorbid conditions that the patient may have. And then, of course, if the patient does have a cholesterol disease, so if their LDL is greater than 100, you should consider starting them on a statin, since they already have, in their hypertension, they already have risk factors for coronary disease, for stroke or TIA, and so forth. All right, so hypertensive emergency is diagnosed a little different. So what a hypertensive emergency is it's just hypertension with specific symptoms. So usually these patients have hypertension that's greater than 180 over 110, but that's not necessarily. So that doesn't necessarily rule it out. But what these patients really are they're hypertensive patients who come in with hypertension, and they don't need to have it 3 times. It could only just be 1 time, and they have neurological or cardiac symptoms. And you need to keep a high index of suspicion on these patients because they might not have a history of hypertensive emergency. This could be something that just comes out of the blue. So something like headache, seizure, encephalopathy, blurry vision, chest pain, dyspnea, palpitations, hematuria. If that's present with significant hypertension that's at least 140 over 90, but even more so if it's higher, then you should generally jump straight to treatment while you're doing your workup, because this can lead to death So keep a high index of suspicion on these patients and initiate treatment while you're doing your workup. So any patient that comes in with these neurological or cardiac symptoms in consort with significant hypertension, initiate treatment while you're doing your physical exam and workup. So your treatment is going to be start your IV lines, and IV nitroprusside and IV labetalol are best for hypertensive emergencies. Nitroprusside, if you had to pick the single best treatment, it's nitroprusside, but usually we start nitroprusside with labetalol. We can also use enalapril in addition if the hypertension is that significant. You're going to want to start cardiac monitors on these patients and have a crash box ready because these patients can go into ventricular fibrillation. You want to follow the guidelines on all these medications. So don't give too high of a dose. You don't want to lower their blood pressure more than 25% in their first couple hours. And definitely, while you're doing your physical exam, while you're doing your fundoscopic exam, while you're treating them, make sure that you do a fundoscopic exam, and if there's any signs of elevated intracranial pressure, so papilledema on your fundoscopic exam, you're going to want to get a CT because this could be a sign of a bleed. So I've gotten this question quite a few times, and what is malignant hypertension? So malignant hypertension is an archaic term, and it shouldn't show up on the USMLE, but what it is, if it does show up on the USMLE, is it's a hypertensive emergency, so what we just talked about, accompanied by fundoscopic changes. So it's going back, it's that hypertensive emergency where you have papilledema and you need to get a CT. So that's what malignant hypertension is. So moving on to secondary hypertension. Secondary hypertension is just hypertension with a cause. So we're doing the same workup as we would. We're doing the same diagnostic procedures that we would do for anyone with hypertension. So we have to see them 3 times. But in secondary hypertension, they're also going to have symptoms that are not necessarily related to the hypertension. They are concurrent symptoms that point towards another disease process. So secondary hypertension is more frequent in the very young and the very old. And the way you can remember this is young people just don't get hypertension. And older people, older than 65, they tend to not just develop hypertension. They'll usually have developed it earlier, and we would have usually found it earlier. So younger than 30 or greater than 65 is going to tend towards secondary hypertension, but essential hypertension is still the most prevalent in these patients. It's just that secondary hypertension is more prevalent in these patients than it would be in patients between the ages of 30 and 65. Secondary hypertension tends to be the hypertension that's refractory to traditional treatment, so we may work them up, we may diagnose them with essential hypertension, and then we give them a diuretic. Nothing happens. We give them an ACE inhibitor or a beta blocker. Nothing happens, and so we have refractory hypertension. It's in those cases when we need to look for other things on the physical exam that may point us to a secondary cause. So the main causes of secondary hypertension is going to be pheochromocytoma. And the reason I bold-faced is because all of these causes have a C in it. Most of these start with the C. So pheochromocytoma, Cushing's disease, Conn's disease, closing of the renal artery, which is another way to say renal artery stenosis, contraceptives, congenital adrenal hyperplasia, and coarctation of the aorta. And here, when I say contraceptives, I mean oral contraceptives. So these are the big 7 causes to keep in mind as causes of secondary hypertension. So these are the different causes of secondary hypertension, and we're going to go over each of these different causes in the different sections, so I don't want to spend too much time talking about the etiology of these. So pheochromocytoma is going to be set apart from all the other ones in that it's going to be episodic, sudden bouts of hypertension, and they're usually going to be accompanied with flushing, pallor, and headaches, sometimes nausea or vomiting. So you want to have a high index of suspicion. here because especially if these are patients that have had multiple bouts of episodic hypertension, but they don't have hypertension all the time. So the way to diagnose pheochromocytoma is to first get a urine sample for VMA, which is vanillamacetic acid, I believe. So these are the various causes of secondary hypertension, and I don't want to spend too much time talking about the etiology of each of these, just because we're going to go over these and the other sections. These three we're going to talk about these three we're going to talk about in the endocrine section. Renal, we've already talked about in the renal section, and then contraceptives is an OB issue, and then these two are pediatric issues. So pheochromocytoma is a set apart from the other ones in that this is episodic hypertension. So these patients don't have hypertension all the time, but they get these rapid episodes of sudden hypertension where their blood pressure jumps and they have flushing or pallor or headaches or sometimes nausea and vomiting. The fact that their hypertension is sudden and that it's been episodic, that's been their history, you should get a urine VMA along with catecholamines and metanephrines. That's going to establish your diagnosis. So if your urine VMA is high, then that's going to be diagnostic of pheochromocytoma. What you're then going to want to do is get a CT or MRI to locate the tumor, and then to treat these patients' hypertension, you want to start IV alpha blockers, and then once you've got it stabilized, then you can give them IV beta blockers. You can't do it the other way around. If you give them IV beta blockers, the patient will quickly decompensate. So you need to give them alpha blockers first, then beta blockers, and then you can wheel them in for surgical removal. And you'll usually do all of these on the same day, but you don't have to. So Cushing's disease, if you've looked at the renal slides, you should remember is characterized by weight gain, edema, hirsutism, buffalo hump, striae, and weakness. So the edema and the weakness and part of the weight gain is due to the aldosterone effects of Cushing's disease, and Cushing's disease is simply a high cortisol. And then the hirsutism, buffalo hump, and striae are directly due to the cortisol. So on complete metabolic profile, you're going to see a high plasma sodium and a low plasma potassium. That's certainly not diagnostic of Cushing's disease, so you're going to need to get additional tests. So you're going to be pushed towards Cushing's disease when you have striae, when you have hirsutism, when you have buffalo hump, and when you have weight gain. So to make the diagnosis of Cushing's disease, you have to measure the cortisol itself. So you need to get a 24-hour urine cortisol. If the 24-hour urine cortisol is high, then you've made the diagnosis of Cushing's disease. But you still don't know where the Cushing's disease is. It could be an ACTH secreting tumor in their pituitary, or it could be a cortisol secreting tumor in their adrenals. So you're going to have to get a dexamethasone suppression test to determine where the tumor is at. And we'll talk about this in greater detail when we get into the endocrine section. The treatment here is going to be surgical removal. Conn syndrome is similar, but this is not a cortisol tumor or a tumor that results in high cortisol. It's a tumor that results in high aldosterone. Cortisol does have aldosterone-like effects at high concentrations, but aldosterone does not have cortisol effects ever. So you're in Conn syndrome, you're going to get the edema, you're going to get some weight gain even, you're going to get weakness, but you're not going to get the hirsutism or buffalo hump or striae that you get from the cortisol. You're just going to have aldosterone-mediated effects. So weakness, edema, maybe some weight gain. And so so the way you differentiate this from Cushing's is that you don't have these emasculating features, you don't have the striae, and you don't have severe weight gain. On labs, you're going to have simply a high sodium and a low potassium. And the way you're going to make this diagnosis if you're suspecting Conn syndrome is to get simply a plasma aldosterone. If the plasma aldosterone is high, in addition to these symptoms, you've made your diagnosis of Conn syndrome, and the treatment here is surgical removal. For renal artery stenosis, these patients, what they have is a stenotic plaque lesion in their renal arteries, and so what happens is you're not getting enough blood perfusion into your kidneys, and so your kidneys are sensing that you are hypovolemic, so they're increasing the renin-angiotensin-aldosterone syndrome, and so essentially you have high aldosterone. The way we need to get around this is we need to get more perfusion to the renal arteries, and so to diagnose renal artery stenosis, first we need to make sure that we do have a blockage in the renal arteries, so we get an ultrasound. That's sort of your screening test because it's cheap and it's easy to do. And then to make the definitive diagnosis, we get a renal arteriogram. Definitely suspect renal artery stenosis in patients with resistant hypertension. Why? Because one of the best drugs we use for hypertension works on the kidneys. It works on the renin-angiotensin-aldosterone system. So what we're talking about here is ACE inhibitors and angiotensin receptor blockers. They're really effective at reducing your blood pressure, but only if your kidneys are working properly. And so in this case, your kidneys aren't working properly, so they're going to be resistant to the ACE inhibitors and to the angiotensin receptor blockers. So when you have patients with resistant hypertension, think renal artery stenosis. If you have patients with a flank bruit, so that whoosh, whoosh, whoosh sound on their flank or even by their abdomen, definitely think renal artery stenosis. Get that screening ultrasound and ultimately a renal arteriogram. The treatment here is going to be surgical. It's going to be percutaneous transluminal angioplasty, which will increase the flow to the kidneys and stop the renal artery stenosis vicious cycle. So contraceptives can cause secondary hypertension, and what you're going to have here is you're going to have a patient who is not pregnant, she's young, she's of childbearing age, and she's using contraceptives, and ever since she started using the contraceptives, or about when she started, or definitely not before, after she started using the contraceptives, she's had hypertension. The diagnosis here is going to be clinical, and it's kind of also going to be retrospective. You're going to tell her to stop using the contraceptives, and if the hypertension abates after she stopped using the contraceptives, you can diagnose retrospectively that this was secondary hypertension due to contraceptive use, and she can talk to her OBGYN about alternative ways that she can use contraception. Things that come to mind are the intrauterine contraceptives or natural family planning. So these two that I put below on the bottom here are things that particularly affect children or are diagnosed in childhood. The first is congenital adrenal hyperplasia. So you would suspect this in any patient that had a neonatal history of ambiguous genitalia, if there's hirsutism, so overgrowth of hair, or if there's any kind of masculinating features, and these are particularly in women. So if it's a little boy who's growing a bunch of hair and has masculinating features, yes, but if it's a man, it's kind of hard to tell. If it's a little girl or a woman who's growing a lot of hair, or has masculinating features, then that can point towards CAH also. The diagnosis here is, since this is an enzyme deficiency, we're going to get a level of the substrate that's proximal to the enzyme, so what's building up, that's going to be 17-hydroxyprogesterone. And so we get 17-hydroxyprogesterone levels. If those are high, then we will commence treatment with fludrocortisone. Coarctation of the aorta is where we have a blockage after the left subclavian artery, and so we get good blood flow to the upper extremities, but we get relatively poor blood flow to the lower extremities. And so what we're going to have is we're going to have high pulses, high blood pressure of the upper extremities because we're getting a lot of blood there, but we're not getting good blood pressure down to our lower extremities. And so what you'll see is when the patient is laying down, you'll feel much, much, much stronger pulses in their upper extremities than in their lower extremities. And that shouldn't happen. They should be even. And particularly when they're standing up, you should have stronger pulses in your lower extremities than in your upper extremities. Why? Because naturally you're supposed to have a higher blood pressure in the lower extremities when you're standing up, because it has to push all that blood upwards against gravity to your brain. So if you have a patient with uneven pulses while they're laying down and they have a higher blood pressure in their upper extremities than in their lower extremities, that definitely points towards coarctation. Any child with hypertension, especially if they have a coexisting murmur, you should definitely think coarctation of the aorta, and also definitely if they had neonatal symptoms. Diagnosing coarctation of the aorta is quite simple. You just get a chest x-ray and you will see the abnormality. You will see the coarctation. And the treatment here is going to be surgical repair. And remember, I talked about another cause of secondary hypertension. And this is something you're going to want to know. This is an OBGYN cause, but I think it's very important to always keep this in your mind, because the patient could be pregnant. And you have to keep that in mind on a USMLE question on a patient that comes into the ED. If no pregnant patient should ever have elevated blood pressure. They should have a lower than normal blood pressure, or lower than average blood pressure, less than 120/80. So preeclampsia is simply blood pressure greater than 140/90. That's measured twice over at least 6 hours. A 24-hour urine protein that shows greater than 300 milligrams of protein, and edema. So always keep in mind preeclampsia, in addition to these other causes of secondary hypertension. And that is it.